Okay, are we good? So the last survivors here. We're all here for this little bit of a marathon. I'm going to try and condense 2 days course, which we do in London in November, into 1.5 hours. So I'm going to have to speak very fast. Okay, and there we have the Slido up there, in case you want to, keep asking questions, and I can maybe interrupt and ask and answer. Okay, so what I'd like to do is to get a little bit inside the complications of corneal refractive surgery. And when I say a little bit, I'm going to dive very deep into certain parts of it. But I'm not going to get you everything, because you can't do that in an hour and a half. If it was that easy, I have one question actually, from the guys at the back. Are you recording this on the video or just projecting it? Are you recording the video? Yes. So, okay, good. So I don't have to video this myself, because I'm looking forward to seeing what this looks like. Okay. So, my disclosures, which have not changed since this morning. Now, about 120 years ago, Röntgen, he devised this method of imaging bone with X-ray. And this is a picture of his wife's left hand. I am sure that when he presented this to the, surgical meeting in Germany, everyone said, I don't need to see the bones. I feel the bone, and I know how to fix it. I'm sure there was resistance to something new, didn't seem necessary. But that is exactly the resistance that I got when I started looking at cross-sectional imaging with high-frequency ultrasound in the early 90s. And the Artemis, which is now called the Insight 100 from ArtScan, it took 20 years to get this thing commercialized. But now it's becoming obvious that in order to fix complications, we need to have a diagnosis first. And so the first part of this little mini course is to go through and talk about diagnostics. What you treat and the methods that we use to treat complications depend entirely on the diagnosis. So this idea that we have from industry, which is do topography-guided treatment, do wavefront-guided treatment. These are very, very simplistic ways, and sometimes they can actually worsen the patient. There's a lot of echo in here, isn't there? Sounds like I'm in a cathedral. Tap, tap. See that? Okay, so thankfully, we do have now a lot of options for OCT imaging. I have many devices, many OCT. I have 6 MS-39s, an Avanti, and 3 Cirrus 500s. In my clinic, I take imaging and diagnostics very seriously. I can talk a little bit about the different devices. The OptoView devices and the CSO devices are the best. The Anterion, there's no validation really of these epithelial maps that I've seen. There is some validation of Precisio, but you can't really buy it. And the Cirrus can give you good images, but it's not calibrated properly. It measures about 10 microns thinner than it actually is, and Zeiss hasn't corrected that. But essentially, the best machine for all of this is the MS-39, hands down. And I just want to go back and show you why I still use ultrasound. And that is because, you see, this is a cornea that had a flap made, and 10 years later, you can still see the interface lighting up like a Christmas tree. And this is one of the reasons why ultrasound is still helpful, because you can see internal interfaces, which will be physical discontinuities, which you may not be able to see by optics, because there aren't any optical discontinuities, because glycosaminoglycans bathe interfaces and eliminate the optical interface within the cornea. That's why the cornea is transparent. So, putting everything together, these are 4 examples of surface topography from Placido rings. And from just looking at the front surface, we may be able to diagnose what's going on, but we may not. So here, this looks not too bad, maybe a little bit irregular. This, would you know what this is just by looking at it? Maybe not. How about this? What does this look like? Anybody? Ectasia. It looks like ectasia, right? Yes, you agree? Okay. So I'm going to show you now the epithelial maps underneath these topographies. So in this example, you have here a nasal hinge, which is short, and the ablation has taken place, and the ablation was truncated. So you have very thick epithelium where the underside of the flap and the bed were both ablated, so you get a trough that's filled by epithelium. This is actually an eye that is 25 years after RK. This here looks very normal, but the patient is really complaining because, and look at the epithelium, has concentric circles in it. And this ectasia is not an ectasia. It's actually a decentered hyperopic ablation, where the tracker fixated on the wrong spot and the surgeon continued to ablate. So there was ablation of the circle of hyperopia through the visual axis. If we go in the other dimension, we see the cross-sectional imaging. And again, you see the step here, you see the RK incision down to 90%, you see the ablation in the center, and you see a highly irregular Bowman's in the case where the epithelium was in rings. So you see, when I'm looking at a complex cornea, I am analyzing it not just from, I look at the front surface, but I want to know why the front surface has a problem. And I'm looking at the epithelial map, which tells me about the contours of the stromal surface, and I'm looking at the cross-sectional images so that I can see whether Bowman's is regular, whether Bowman's is missing. Like here, Bowman's is missing. That's because it had ablation with an excimer laser, and here it's not missing. So there's still Bowman's there. So I'm looking at all these different factors. So now that you're an expert at this, let's look at this topography. So would somebody like to tell me what they think this is? What do you think this is? You're all very quiet. You want to put your Slido up and so you can anonymously say things so that you don't trip up? This looks like a terrible decentration. Would you agree? That's what most people would say. Actually, if you look at the cross-sectional imaging, this is the horizontal cut. Multiple cuts all over the place, disruption of Bowman's, and if you look at the vertical scan, it's a complete disaster. There's a huge amount of stromal tissue missing from the middle, and as you can see, multiple layers. So you see, you cannot judge a cornea by its cover. You have to look at cross-sectional imaging. And by the end of this hour and a half, you're going to realize why you have to be, well, you really shouldn't do any topography-guided treatments for repair if you don't have cross-sectional imaging. And you will understand this by the end. This is an example of a topography after a Q slider -5 correction for presbyopia, which made a central island. The patient draws this around a light. This is the wavefront, but the epithelium has this donut around the bump. So you see partial compensation for the central island created by the Q slider in a myopic treatment. This is why Alcon now has commercialized their Q slider for presbyopia, but only for hyperopia. Because if you do it for myopia, you get central islands. So going back to anatomical diagnosis, I'm going to now go through a case. And this case is a patient who had PRK in 1995 and then LASIK in 2001, an enhancement in 2006, another enhancement in 2014, and then ended up with 30 post-op visits after that last enhancement in the left eye. The letter of referral said that the patient had epithelial problems under the flap, and that's the left eye refraction was plus 2.75 minus 525 at 172. Best spectacle corrected 2040 minus 2. The other eye was also down one line of best spectacle corrected vision. This is the right eye topography. This is the left eye topography. Now, you could say this doesn't look too bad, but you're not quite sure what's going on, right? We're not quite sure. So let's look. That's the slit lamp appearance. Exactly. That was exactly my reaction when I saw that. I was like, what am I looking at here? I have no idea what I'm looking at. I really, like, what is going on here? It looks like a Jackson Pollock on the cornea. Well, you put fluorescein in the eye, and you realize that there is a sort of heart-shaped, smooth area here. There's a sort of fold, looks like some kind of gap here. And over here we can see that the part of this half of the heart shape here has reticular haze inside it, and it has epithelial ingrowth under what looks like the flap, and that looks like the edge of a flap. In other words, this must be molten area, like melt, with no stroma, and you have direct epithelial stromal contact, which means that you get chronic inflammation from the epithelial ingrowth, causing reticular haze. So now we're going to look at cross-sections of this. Here's an opto-view cross-section through here, where we see the flap ending here, right here, and then you have the reticular haze along here, and then you have a bit of flap down here, and you have epithelium under that stromal component of the flap. Here's another cut. We go through here. You're coming from flap to an edge where the flap ends. Then you have reticular haze right here. That's this little nubbins here. And then here you have epithelium under the stromal component of the flap. So this is all epithelial ingrowth here, right? And you spend some time at the machine looking at the cross-section and trying to build a three-dimensional picture in your mind of what you're looking at. This is the ultrasound image of the same eye, the horizontal and the diagonal. So you can see that there's different layers. And the other angles. So I said to the patient, you have multiple planes, you have epithelial ingrowth, you have haze, which is reticular, and you have a highly irregular astigmatism. And I cannot tell you exactly how I'm going to fix this. So what I need you to give me informed consent to do any procedure. I want to take you to the operating room, and I want to examine your cornea under the microscope in layers. I'm going to open the flap. I'm going to do a physical exam. And you remember in medical school, they used to call it an exploratory laparotomy. Do you remember that? When they weren't sure if it was an appendicitis or something else, or a bowel obstruction from adhesions. So you do an exploratory laparotomy. So I said, I need to do an exploratory keratoplasty. So I consented him for multi-stage LASIK enhancements, flap lift with repositioning, PTK, PRK, PTK for corneal irregularity, flap removal. I wanted the option to maybe remove the flap. And so here's where we're starting. And what I decided to do was to map this out so that I know exactly where I am. And I print this and I bring it to the OR. And I look at it upside down so that I'm looking in the microscope, but I've got my reference image here on the side. And so what I did was I started opening the edge, and we're sort of trying to do the thing. And then I sort of get the edge, and it opened very easily. So I realized that the epithelium that was under this flap was actually quite easy to remove. And so I decided to, because the stromal component of the flap was quite rigid still, it wasn't thin, it wasn't very melted, I decided to preserve those two wings of flap and to do just a clean out, only. And then I decided to suture the edges, just to make sure that the periphery doesn't get ingrowth, because obviously his problem started because of the ingrowth. And, suture. So this is one of the reasons why it's a pretty good idea to have cornea training before you are a refractive surgeon, because, you might need to use all of your skill set. I do suturing maybe 2 or 3 times a year now, so it's a little bit slow. But thanks to the magic of movies, I can make it look like I'm a really slick suture. Okay? So the treatment really was essentially lifting the flap to the purple line, and in the central scar area, leaving the epithelium intact, and then removing the epithelium and leaving a little buttonhole that was created here, where there was no stromal component of the flap, putting in 8 sutures and a bandaged contact lens. So this is what the patient looked like on post-op day 1, and this is at 2 weeks. And you can see that I can tell that there's a little bit of epithelial ingrowth which is returned, obviously from this side, from inside. It was too thin and too central for me to want to put sutures in there. So I was kind of expecting that, but that's okay, because at this point what I do is I put very low energy spots in there, very low energy YAG spots into the interface, about 0.4, 0.6, just enough energy to make a bubble. And actually, it has a really effective way of activating macrophages, so the macrophages come and chew up the epithelium for me. This is what it looked like at 3 months. So we'd reduced the cylinder considerably, and we gained a little bit of best spectacle corrected vision, but we still had a relatively irregular cornea. But if you notice, the haze is a little bit less. Do you see that? I didn't use mitomycin, I didn't do a PTK. And then at 7 months, the cornea was even more regular, and the haze was even more reduced, and the best spectacle corrected in the cylinder went down a bit more. And so basically in 7 months, we went from plus 225 minus 525 to plus a 0.5 minus 0.75, and we gained a little more than 1 line. This is the pre, and this is 7 months post. So topography-wise, we've made a huge improvement just by cleaning the epithelium and letting everything heal up. Now, why would I have done just that rather than doing more? Well, because in therapeutic refractive surgery, you cannot put stroma back. So if you can preserve stroma, that is a good thing, because you can use stroma for topography-guided treatments. If I had amputated the flap, I am now compromising my options in case there isn't enough tissue to do regularization by topography-guided treatments. So my aim here is to clean the situation up and preserve tissue. And as you can see, by 1 year, things were looking actually a hell of a lot better compared to where we started. So, finding out the actual cause of the irregularity is what guides you as to what to do. And I call that first case the knife and fork case. Because I'm not using a laser, I'm doing nothing fancy, I'm using a knife and a fork, and I'm just manipulating things, suturing, cleaning the situation out, no laser involved. And look at how much improvement you can get just with knife and fork. But of course, we want to move on to what we would do next. I can't hear. Can you use Slido? Come up here and say it loud. Or do we have a microphone? Do we have a microphone? Can we put the microphone here at the front? Did I do nothing? So you speak into the microphone. That's right, I did nothing. So what happened here was the ingrowth was causing chronic inflammation. The chronic inflammation was chronically activating keratocytes, turning them into myofibroblasts, which laid down reticular haze. By taking out the epithelium, 1, I regularized the surface. 2, I removed the haze because I removed the injury, the reason for the haze. So I've really cleaned up the situation here quite a lot. How we proceeded from here, I think, comes a little bit later. But first, let's just go to understanding how the basic approach to corneal refractive surgery complications is to divide everything into simple aberrations and complex aberrations. Simple aberrations is coma and spherical aberration. Complex aberrations is irregular corneas. If you have coma, that's a regular irregular cornea. It's regularly irregular. But if you have lumps and bumps all over the place, that's an irregular cornea. And that's the subdivision that we want to go for in the beginning. And we're going to move on to part 2 here, which is talking about these two options. So, let's go to simple aberrations, okay? Simple aberrations are spherical aberration and coma, like I said. We published the first topography-guided retreatment paper with corneal wavefront topography-guided treatments in 2009. This was with the Tosca software, which was modified from the MEL 70 onto the MEL 80, and we showed that you could expand an optical zone, you could recenter an optical zone with asymmetric profiles, and in this study we really showed massive improvement in these regularly irregular corneas. So spherical aberration, if an eye has very high spherical aberration, you can reduce the spherical aberration with one of these. And remember, I talked about this yesterday in terms of what spherical aberration is, the fact that the brain can filter quite a lot of spherical aberration, so you don't have to make it 0 to make the patient be able to see things. But if you have a toxic level of spherical aberration, this is, let's say 0.55, and then a toxic level would be 1.24. That is completely abnormal, and that would need fixing. And this I had both very high spherical aberration and very high coma. So in our topography-guided treatment, we showed that it was much more effective than wavefront-guided treatments. So when we matched controlled for pre-op spherical aberration and coma, we were able to reduce the spherical aberration far more with topography-guided treatments than wavefront-guided treatments. There's a number of reasons for this, the main one being that wavefront-guided treatments are limited to the pupil size. And so, whereas a topography, you measure the whole cornea. So you can do a 7 or 7.5 millimeter zone on a topography-guided treatment, which you maybe can't do on a wavefront sensor that doesn't go out that far. Anyhow, in this publication we showed, incredible ability to reduce coma and spherical aberration. We had the ability to take a very, very small Vizix central hyperopic terrible ablation and turn it into a reasonable, better centered, wider ablation. That's the difference map. Coma. So he obviously, this is what his cornea looked like. It was like I call it the Zorro treatment. He's like, zoom, 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 zoom. And he had plus 650, minus 8, best corrected 2050, which is not what you would expect from that topography. Topography didn't look too bad. A lot of sill, but you see the epithelium was very irregular. And so this is what's interesting, because topography-guided treatments are based on the topography. So if we think of the topography as a asymmetry, that is the surface which is going to be converted into an ablation profile. But you see the epithelium is compensating for asymmetry. And so therefore, that is the surface that we need to regularize. So let's say that you look at the stromal surface topography versus the front surface topography. Now, today, you can do this with an MS-39. But back in 2012, or 2010, the only way of doing this was to use an experimental research software program called VolPro-CT, which you could import OrbScan or import epithelial maps and subtract the epithelium from the front surface and derive the stromal surface. This is a research tool. So what we found was that the superior to inferior difference was 5.8 microns, diopters on the front surface, but it was 9 diopters on the stromal surface. So topography-guided treatment would not get even close to correcting the irregularity in this cornea. Instead of basing the topography-guided treatment on regularizing the front surface, which would of course be removed from the stroma, which then of course would still leave irregularity, what we really should be doing is stromal surface guided treatments. But we don't have that. So we do a transepithelial PTK. And we do the same thing. We have our simulation of the transepithelial PTK. We stop at 55 microns, and this is the amount of stroma that would be removed by then. And then we inspect it. And this is early days. We were doing this, just like by feel. And what does that look like? Well, it looks like hyperopic astigmatic correction, because you're taking tissue from above and below, but not the middle. And if you compare that, which is a 24 micron difference in a 4 millimeter zone, that actually calculates with the Munnerlin equation to a plus 350 SIL. So we do the whole thing. We have our photostop opportunity where we see the breakthrough pattern as expected at 45 microns. And here is after 1 PTK. So after 1 PTK, we halved the astigmatism, and we made the best spectacle corrected go down to 20/20. The patient is now plus 450, minus 450, instead of plus 6, minus 8, and that's the difference map. Now, if we look at the epithelial profile before and after the PTK, here is where I learned something. To me, this looked regular. So I said, well, if the epithelium is now regular, now I can do a topography-guided treatment, because now the stromal surface is represented by the front surface. So I did a topography-guided treatment. By the way, that's the predicted stromal removal, and that's the actual stromal removal by difference maps of the stroma with ultrasound. Of course, like I said, taking the corneal topography and subtracting the epithelium and getting the stromal topography is actually what we really want to do in the end. But we can't do that. So I did a topography-guided treatment, and I went from plus 450, minus 450 to plus 4, minus 350. No change. Why didn't it change? Well, it didn't change because there was a cylindrical epithelium. There was much more cylinder on the stromal surface than was showing on the front surface. The epithelium was a cylinder, filling a cylindrical hole. So I corrected the cylinder on the front surface, but I'm left with what was being masked by the epithelium. It's a beautiful example of why topography-guided treatments don't work sometimes. But we're way better off. That's the ablation profile that we put in, and that's the difference map, but it's not right. So I brought him back again, and because now the epithelium was regular, now I did another topography-guided treatment, and I am not joking. He didn't have sphere and he didn't have cylinder, and he was 20/20, and his cornea looked like a pre-op cornea, and that's pretty incredible, and that was an ablation profile like this. He then had LASIK in the other minus 6 eye, which he had lived with a contact lens for 30 years because he didn't go back after the RK. Okay, so we're talking now about transepithelial PTK, and let's talk a bit more about transepithelial PTK. Whoever anonymously said, from all this, and also based on the wavefront measurement principle, based on the center of the pupil, there's actually no place for wavefront guided treatment. That's a very profound statement, whoever made that, and actually, it's almost 100% true. So the only place currently where there is a place for wavefront guided treatments is in, for example, a case where the front and back surfaces are irregular. So like in a keratoconic asymmetric treatment, there's a cone on the back surface. There's irregular astigmatism on the back surface. So if you correct only the front surface, then you have no compensation for the back surface irregularity. So in a wavefront guided, you're measuring the whole eye, which includes the front and back surface of the cornea. The problem with that is that the center of the ablation, as you've mentioned there, is in the center of the pupil. And so it actually doesn't work as well as we'd hope. But you're very right. Really, it's topography guided. And really what it should be is ray tracing through the cornea, epithelium and stroma, and then deriving an ablation profile to regularize the stroma, and then knowing what the epithelium is going to do on that surface. I'm going to finish with that. So just because we need to understand in more depth what PTK does, transepithelial PTK does, I'm going to show you a study that we did on all of the PTKs that we'd done up to a certain point. It was 29 eyes with 12 months follow-up. And we looked at the outcomes. So the uncorrected vision got better in half the patients and got worse in half the patients. The uncorrected vision, meaning we worsened the refractive error in half the patients, and we improved the refractive error in half the patients. Now, looking at the refractive change of a transepithelial PTK, sometimes we had a hyperopic shift, sometimes we had a myopic shift. Looking at the outcome in terms of best spectacle corrected vision, we almost always improved the best spectacle corrected vision with a transepithelial PTK. It's almost never made them worse. And that's because you're protected by the fact that the epithelium compensates for the stromal surface irregularities. It's impossible to take tissue away from the stroma where there isn't a bump, because the epithelium is going to break through over the bump, and that's where you're going to start to take tissue from. So Tim Archer suggested that we call a parameter the epithelial thickness range, the ETR, and that is the difference between the maximum and the minimum in a zone of irregularity. So in this case, we had an ETR of 79, and it decreased by 43, and now it's 36. So we can measure the improvement, right? So we have an ETR of, 79 minus 43 is 36, and after the surgery it's 58 minus 48, so it's only 10. So the ETR was improved by 1 transepithelial PTK. And because the epithelium was able to fully compensate for the 10 micron ETR, we don't see it on the front surface anymore. The population statistics were that this is the range, and this is the box plot for epithelial thickness in these irregular corneas before, and this is after treatment. And that tells us that this is all of the individual eyes. We reduced the ETR in 89% of the cases, but never reduced to 0. Why was it never reduced to 0? Because the epithelium doesn't fully compensate for the irregularity, and therefore it partially compensates for the irregularity. Therefore, a transepithelial PTK will only correct the irregularity that it has compensated for, and what's left is not in the epithelial profile, masking the situation for you to improve the regularity with a transepithelial PTK. So, one question we often get asked is, how long should you wait before you do the second PTK? And the answer comes not from our LASIK study, where we looked at the epithelial profile in 10 eyes at 1 day, 1 month, 3 months, 6 months, and 12 months with high-frequency ultrasound, 1 micron precision. And we found that most of the change happens overnight, and then a little bit of change from 1 month, from between 1 day and 1 month, but the epithelium is completely stable by 3 months. In surface procedures, a study that we did with our colleagues in Tehran, because they do a lot of PRK there, we found that it takes 6 months for the epithelium to stabilize. So we say to have the best result from a transepithelial, to get the most compensation before you do the next regularization, wait 6 months. So 6 months is the answer. Now, part 5, and this is the last part. Wow, I can't believe we're actually doing this. I can't believe you're still here. Are you still here? So I can't see anything. Oh, you're still there, okay. Oh yeah, I can hear you. Okay, thank you. Okay, so PTK, which is the thing that I want you to go home with PTK on your brain. I want you to realize what a powerful tool this is. And the MEL is phenomenal at PTK because you can do an 8 millimeter zone up to 100 microns in one go. Don't do it because it's way too much tissue heating, sorry. But this is the Louvre, and this is we have a gallery in there with all of the examples of these transepithelial PTKs. We have, I don't know if you've been to the Louvre, but there is a section which is called the transepithelial PTK gallery. No? Yeah. It's downstairs, and I think it's the second left, and then go to the right, and then go past the popcorn stand, and it's right there anyway. You ask any of the guys, they know where it is. And so here's an example of a highly irregular stromal surface again from, again, a double ablation. And you can see how we completely regularized it. This is the topography before, this is the topography afterwards, that's the difference map. This is the other eye, nasal hinge, double ablation, highly irregular, much more regular. You can actually see the epithelial thickness profile regularizing, that's the difference map, the topography improving, difference map. And this is the patient's own subjective point spread function. You show the white dot at the end of the room with the best refraction, and this is the right eye, this is the left eye, but that's the right eye, and this is the left eye. And this is what he had after one PTK. Beautiful. And then here is an incredible topography in a novice LASIK surgeon who received inadequate training. He worked at he was a cornea specialist, and he was hired to do surgery at a chain in the UK where they just teach, it's see one, do one, teach one, right, without the teach one. And he basically had one day of training and off he goes. So he didn't know that you had to wipe the bed and not leave a drop of water on the bed while you're doing the ablation. And so he ended up with no ablation over where the water drop was, which left a massive bump on the surface, and obviously a terrible irregular astigmatism. Look how it's smooth, not 100%, but it's smoothed out the bump. Epithelium now completely regularizing and having a regular astigmatism left on the surface. One treatment. And that's the difference map. And then, I'm afraid to say, the same surgeon on the same day generated another one. This is a rather cartoon-like thing where you have the two eyes there, the hair, the smiling, the epithelial profile. Here's the transepithelial PTK. This is the difference map, which is an exact, mirror image of the pre-op. And then we present. We have two courses at the ESCRS on therapeutics. The first course is something like what I'm just doing for you now. And during that course, we say on Monday or the next day, every year is slightly different, but the first course is the theoretical course, which is what we've just kind of done. The second course is the live. We have a panel of experts, and the audience brings cases to us, either during the year, you can email them to me now, and then we go over with you and we make a presentation, and then you come on the podium and you present the case. And then the panel goes through and makes suggestions. And Stefano Guglielmetti from South Africa presented this case of highly irregular astigmatism. We told him to do the transepithelial PTK. He did it, and 1 year later, he had a brilliant result, and he had another case also, and we published both of these results, and then he presented the result the year later at the live course. So we've got like this sort of continuity of teaching, where it's a little bit like grand rounds for therapeutics. You have the experts panel, you bring your case, we tell you what to do, you come back the next year, you show us what happened. Yeah? So you're welcome to send us cases. Like I said, the holy grail is going to be to do stromal guided ablation, and that is what I'm working on now. But believe it or not, the first treatment I did was in 2001. I was a very important client of Bausch & Lomb because I was the medical director of LASIK Vision Canada, and we were doing 100,000 procedures a year, which means 50,000 blades for the Hansatome. So we were a big customer of Bausch & Lomb, and I bullied them into giving me a topography-guided system, which they had at that point called TopoLink, and I bullied them into doing an epithelial subtraction map. So you have this case with a short flap, which I showed you the last case, short flap, double ablation, high myopic ablation, exactly what you saw before, highly irregular cornea, but epithelial thickening inside the trough and thinning over the bump. And I sent the epithelial map to Gerhard Yosefi, who's the R&D director at the time. I think he still is, actually. And he subtracted the epithelium from the topography. He made the topography-guided treatment based on the stromal map, and we applied it to the cornea. And this was the result. We had a significant regularization. The ETR went down from 56 to 30, the difference map. This is the topography. This is the difference map. So you can see the improvement in the ring here, reducing the bump there. Fortunately, we reduced it sufficiently that it's outside of her pupil, and we fixed her night vision. And how do I know, and by the way, the follow-up was done 13 years after the first procedure. I left Vancouver in a rush, long story short, and we lost touch with the patient. And then 13 years later, I was in London, I went on Facebook, I looked for her name. There were 4 people with the same name in Vancouver. I looked through their profiles, I thought this must be the one. I sent her a message, she said, "Yes, Dr. Reinstein, you saved my life, my eyes are great." I said, "Great. Would you mind going to a friend of mine in Vancouver who has an orb scan and get a scan for me and get your refractions?" So we published this case here. It's a publication, 13 years follow-up for the very first stromal surface guided treatment ever performed. So we're very proud of that. So in summary, we're here at the end. In summary, this is what we've learned. Wavefront guided ablation corrects less than topography-guided ablation. It will reduce spherical aberration, but you have to have a zero-angle kappa to be able to do these, as pointed out from over there. Topography-guided ablations are more effective than wavefront. The treatment is calculated from the visual axis, which is the center of vision of the patient. It's the best option for small optical zones or decentrations, but you don't know if it's a decentration or not unless you have an epithelial map, because it can look like a decentration, but it can be a highly irregular stromal surface. The effect, of course, is limited by the fact that the epithelium compensates. And remember that there is a refractive effect to the epithelium, which is why if you have an irregularly irregular astigmatism, you cannot do topography-guided or wavefront-guided treatments. You have to do a transepithelial PTK first. You have to have the epithelial thickness map because it gives you more information than the topography, the best option, and the effect, of course, is limited by how much the epithelium was able to mask on the stromal surface. So you must use that as the first procedure, and you must repeat it if it still has an irregularly irregular epithelium until you have a regular epithelium. And once the epithelium is regular, then you can use a topography-guided treatment, because now the topography is representing the stromal surface. Of course, we're going to want to get to stromal-guided topography treatments, and that has the potential of really correcting everything, but we'll need to know what the epithelium is going to do over the new surface, and that is actually the work that we're doing now, is using actually a sort of AI system that is allowing us to predict what the epithelium will do after the stromal surface guided ablation. So summarizing the whole of that last slide is irregular astigmatism means irregular epithelium. You have to make a diagnosis in these irregular corneas. You need epithelial thickness mapping or you cannot proceed. You just don't know what to do if you don't look at the epithelium. Transepithelial PTK is always, almost always the best option and very safe for any highly irregular cornea. Wavefront and topography-guided treatments can make things worse if you don't look at the epithelial thickness profile. And remember that the effect of the transepithelial PTK is limited by the fact that the epithelium can only compensate a certain amount. So you may have to repeat it. And remember that transepithelial PRK or PTK gives you an irregular breakthrough pattern. And that irregular breakthrough pattern can actually cause a refractive shift, which is why trans-PRK is worse than standard PRK in results. Until we have exact mapping of the epithelium and exact stromal tissue removal planning, we're not going to be able to do trans-PRK with the same accuracy as PRK. Okay, I'm going to simplify it even more. And basically, the world is divided into two categories. You have regularly irregular astigmatism, where most of the error is in the topography, and then you have some epithelial compensation, in which case you can do a recentration or enlargement of the optical zone, because the epithelial profile is regularly irregular. But if you have irregularly irregular surfaces, then most of the information is actually in the epithelium. And so you must do a transepithelial PTK first to try and regularize the stromal surface. And when the epithelium is regular is when you can go and do a topography-guided treatment. So I suggested starting a section in the Journal of Refractive Surgery. I was one of the section leaders for the biomechanics section together with Cynthia Roberts for 10 years. And then I left that and I had Scarcelli come and take my place. And I started a new section in the Journal of Refractive Surgery, which we called Therapeutic Refractive Surgery. And this is a very interesting editorial. I'd strongly encourage you to read it because it's talking about, of course, is also correctable, and we come to a case report which teaches you everything you need to know about centration in refractive surgery. So this is the patient who presented with this topography. Forget about the way that he got that topography. And in the wavefront measurement with the Waska, which was 4 times the resolution of all the other aberrometers at the time 20 years ago, we had a lot of spherical aberration and no coma. But you can see that this looks like a decentration, doesn't it? How can you have a decentration with no coma? Any ideas? Well, there's a huge angle kappa, and the angle kappa is inferior. So the surgeon centers the procedure on the pupil, which is superior. And so the treatment is centered off visual axis. And if you do a topography wavefront, which is centered around the vertex, you actually find huge coma. You also have spherical aberration, but you have huge coma. So this is interesting because you have the same eye measured with the highest resolution wavefront sensor available in the planet at the time, and a corneal aberration map. And they're 2 completely different set of aberrations. And then you look at creating the ablation profile for each of these. And the ablation profile for the wavefront treatment is completely symmetrical. And the wavefront profile, ablation profile from the corneal wavefront is completely asymmetric. So, doctor, you have two devices producing two different ablation profiles on the same eye. Which one are you going to pick? There's one company that said wavefront-guided is the best, and there's another company that said topography-guided is the best. And it's the same company providing both these maps on the same device. Now, you know, this is why it's so confusing, right? Because just thinking about it as like, oh, I'm going to put the that tube. I'm going to use the screwdriver. Oh, that didn't work. All right, I'll use the pliers. Oh, that didn't work. Well, you know. So obviously, it's kind of obvious that this looks decentered, and I'm going to use this profile. So I did use that profile. And when you look at the corneal wavefront, the coma went down from 1.93 to 0.29, which is like normal. The spherical aberration went down. But if you look at the pupil-centered wavefront, which is from a wavefront sensor, the coma didn't change. The spherical aberration went down, but the coma didn't change. Remember, topography wavefront is measured from the vertex of the cornea. Whole eye wavefront is measured from the center of the pupil. So if there's an angle kappa, they're not going to be the same. Now, you can see why a wavefront guided treatment would not have helped this patient. It would not have changed the asymmetry around the visual axis. Other examples of fixing coma with the same system. And here's an example of a small optical zone with a Bausch and Lomb laser, and use a topography-guided treatment to increase the donut of epithelium further out and better centered. Here's an example of another hyperopic ablation, a +4 done on a BNL 217, very small optical zone, and only 5 millimeters, even though it was programmed as a 6, and you can expand that to 7. So we published a paper specifically on regularly irregular astigmatism, so zone enlargement and recentration only. And what I wanted to do was to look at my series to know what the chances are that I would need topography-guided treatments in my practice. Because there's a lot of people who have excimer lasers, but they don't do topography-guided treatments. They haven't paid the extra for the software, or whatever, or the system doesn't do it. Like, you know, NIDEC doesn't do it, Vizix doesn't do it. So you have a system that actually doesn't even do it. So you bought a machine, you bought a car without seat belts, yeah, without airbags, because you can't repair, you can't be ready for an accident. And out of almost 10,000 eyes, I needed to do 73 topography-guided treatments, which means that the probability of an expert refractive surgeon, if I might call myself that, the probability that an expert refractive surgeon is going to need topography-guided treatments to help their patient is a little under 1%. So if you do 300-400 eyes a year, you're going to have 3 or 4 eyes a year that are going to benefit from topography-guided treatment. It doesn't sound like it's not worth spending the money on the topography-guided treatment. I disagree with you, because if you don't repair that complication, the patient's going to go online and get depressed, because they're going to find other people who have not been repaired, and then they're all going to form a little bubble, and then they're going to, you know, rile themselves up, saying that doctors are terrible people and LASIK should be stopped. And they're right, because they're suffering and they've been told there's nowhere out. Or you can say, listen, I don't do this, but there are people who specialize in this, and, you know, you should go to this surgeon, and I'll write to him and I'll connect you with him. So with the topography-guided treatment with the MEL, we have really good accuracy on refraction. And now, you know, other systems, you often will tell the patient it's going to be 2 stages. One, to smooth the cornea out and 2 to do the refraction. With the TOSCA, we tell the patients there's only a 20 to 30% chance that you'll need a second procedure. It's not as accurate as a primary procedure, but it still is pretty accurate. So if I have a plano patient with night vision disturbances, the chances are they'll still be plano after I've done the topography-guided treatment. This is all of the centers of the ablation, the centers of the pre-op decenter treatments, and this is the post-op, showing you that the centration ends up being with a bias of 0.2 millimeters with a standard deviation of 0.14, which is exactly the same that we get with our primary treatments. That's how good the centration is on primary treatment. So we're converting a completely distorted decentration population into as if there wasn't a decentration group post-op. There's massive reduction in spherical aberration in coma, and this is an incredibly effective treatment. So topography-guided treatment is more effective for both spherical aberration and coma reduction because it's based on the vertex of the cornea, not the center of the pupil. It respects the visual axis, not the pupil center, as in wavefront correction, and all of the aberrations that are seen from the perspective of the patient, which are centered on the vertex, not the measuring device, which is the center of the pupil. It's pretty accurate in leaving patients emmetropic, and it can be used for both myopic or hyperopic decentrations or zone expansions. And actually, it takes less tissue than wavefront guided treatments. So don't forget, however, that higher order aberrations are good as long as they're not in a toxic level, because higher order aberrations increase depth of field. So we got to keep that in mind, because like Presbyon works on the fact that higher order aberrations are good. So if we go on to part 3, we're now going to talk about irregularly irregular corneas. So we've talked about regularly irregular corneas and topography-guided treatments. And I'll mention that, yes, so the topography unit that connects to the MEL 90 is the Atlas. And that is shortly going to be moved over to the MS-39. So it's already in the works. What was I saying? Topography-guided treatments. When we do the full course in November, we will talk about the details of how you program a topography-guided treatment. And it involves 3 levels of vector analysis and an MS-39 and an Osiris, because we need to know the front surface, the back surface, and the lens astigmatism, because that's how you get the whole thing to work in one way. So I'm going to go on to irregularly irregular corneas. And how many people here remember George Waring III? Yeah. Lovely guy. He was like he was total, absolute mentor to me. And I felt, I was in my 30s, and I became very good friends with him. He loved jazz, and whenever we went to the Academy or the ASCRS, he would accompany me. We would go to jazz clubs. I would sit in with the band. He was like my agent. He would go up to the band and get me on stage, And we were skiing together one weekend, and he said, you got to publish your stuff, man. You got to send it to the JRS. I know. I said, it's interesting, because I don't think anybody has ever described this fact that the epithelium fills all these nooks and crannies and smooths out the stromal surface. He said, I think if you look in the 1921 textbook from Alfred Vogt on how to use a slit lamp, I think you might find something in there. So I go online, I find it at a secondhand bookstore, they have a copy. $50, I open it, and I find corneal stromal defects are filled with surface epithelial cells, 1921. Pretty good, yeah? There's no such thing as a new idea. So I don't mind being second to Alfred Vogt. Anyhow, what we learned from measuring the epithelium in 3 dimensions was that the epithelium changes no matter what you do to the stromal surface. If you change the stromal surface, you will change the epithelial profile. So, in all situations, so if you have steep areas, the epithelium will thin. If you have flat areas, the epithelium will thicken. So, right when I started doing this is before I started really publishing a lot on this was ARVO 1994. I had a poster at ARVO called Epithelial and Corneal 3-Dimensional Ultrasound Pachymetric Topography Post-Excimer Laser Surgery, where we're examining irregular corneas. And the overall poster conclusion was what we now call the law of epithelial compensation, which is that if there is irregular astigmatism, there is irregular epithelium. Guaranteed. Why? Because if an eye presents with irregular topography, by definition, the epithelium has reached its maximum compensatory function, leaving irregularity on the surface. If an eye presents with a regular topography, the epithelium might have fully compensated for the stromal surface irregularity, and so you cannot see it. But if the epithelium can no longer compensate for what the full irregularity in the stromal surface, then the topography will be irregular. Okay, so that simply means irregular astigmatism, irregular epithelium. Yes, it's very good news that the MS39 is being connected. I agree. So here's the problem with blind repair work, which is what some of the companies push surgeons to doing. There's one company that says that everybody should have a topography-guided treatment all the time. And this is really not very scientific, because you see, you can have 3 exactly the same surfaces with completely different stromal surfaces. So these are not the same eyes. It's not the same optics. So the rules of epithelial healing, which I first presented at the Academy in 2012 in a keynote lecture, the epithelium always thickens to fill depressions. The epithelium always thins over peaks, thickens over troughs, it thins over peaks. The epithelium is changing proportionally to the amount of stromal change. So if you do low myopia, you get less epithelial compensation than moderate or high myopia. If you do a hyperopic ablation, the central epithelium gets thinner the steeper you make the cornea, but the more ablation you do, the thicker epithelium filling the trough gets. Keratoconus, the more severe the keratoconus, the thinner the epithelium gets, and the thicker the donut around it gets. The amount of epithelial change is also proportional to the rate of change of curvature of the stromal surface. So if you have a very small irregularity in the stroma, for example here, in this was one of the very first scans I did in a human. This was at Cornell. The patient had a corneal ulcer which had healed. And I scanned the patient. We only had a very narrow window. And you can see it's a 200 micron epithelium in a 1 millimeter diameter. So it was a little punched hole with a 200 micron fill of epithelium. And that's because the rate of change of curvature is severe. And so the epithelium does 90% compensation. If you have an example here where the hole is bigger, so for example, a 4.5 millimeter hole instead of 1 millimeter, you get 40% compensation. That is exactly what was happening when we were doing PRK in a 4.5 millimeter zone in 1994. So we got a lot of regression when we did a PRK for -3. The patient could come back -250 because the epithelium would really fill the hole. And David O'Brart, while he was John Marshall's fellow, he was the one who published these papers showing that if you make the optical zone wider, you get less overshoot and less regression. And that's because the lower the rate of change of curvature, the less the epithelium compensates. Obviously, no one has a monopoly on good ideas, and within a few years later, Paulo Vinciguerra also was working on using the NIDEC to expand the transition zones. And he would do a 6 millimeter ablation zone with a transition to 10 millimeters. And he was showing that there was very little regression or very little change in the epithelium because the rate of change of curvature was very, very shallow from the periphery to the center. So he calls it curvature gradient. So the whole point here is that you cannot judge a cornea by its curvature, by its map. You have to measure the epithelium. And I don't know how much you're aware of this, but I've published, if you remember, I started measuring the epithelium in 1991. I made the first map of the epithelium in 1993, published 2 papers in ophthalmology in 1994, and it wasn't until 20 years later that anybody else could map the epithelium commercially. So I had 20 years of people ignoring me and saying that there was no need for epithelial measurements. And so I published about 50 papers just on the epithelium. And that means that all my friends, they think that I'm very shallow. That's a joke. Can I have a little bit of are you alive? Are you awake? Okay. So let's go back to these cases, right? So we're going to look at this first case here, and now we're starting to get into what we do about it. What do we do about it? So we have a very irregular cornea, and we published this paper as a teaching example of how you fix highly irregular corneas. So this guy had a low hyperopic LASIK done on a 217 with a Moria disposable which had a nasal hinge. And post-op one day, he was overcorrected as expected with the 217, huge overcorrection because it's a small optical zone. But the surgeon diagnosed a decentration. And a few months later, he did a topography-guided treatment to improve the decentration. Now, the refraction improved a bit, but the patient was still complaining of night vision disturbances. So he said, well, the topography-guided treatment didn't work, so I'm going to do a wavefront-guided treatment. He did a wavefront-guided treatment, and now the patient got worse. Now he said that he had double vision, ghosting, headaches, starburst halos, glare at night. The surgeon is in England, north of England. He referred the patient to me. The patient, when I saw him, was plus 0.75, minus 0.75 at 75. He was best corrected in 2016, but he had a lot of night vision disturbances. And you can see why. His whole eye aberrations were huge amount of coma, like astronomical coma, astronomical spherical aberration. And he had practically no angle kappa, 0.2, 0.1. So the whole eye wavefront was basically the wavefront. Now, the fact is that with cross-sectional imaging, I was able to show that this was not a decentration. This was actually the anatomy of the flap. And we can see that the flap interface actually finished short of where it should have been. And the stromal surface had a highly irregular dip here nasally. So the epithelium basically filled the hole. So the hypothesis was that the flap was created and lifted. The hyperopic ablation was done, but unfortunately, the nasal hinge wasn't protected, and so there was ablation of the underside of the flap and the bed, essentially in the same location. So when the flap went back, the stromal surface, of course, collapses, and then the epithelium fills that. And that's exactly what we see here. We see filling of the trough and thinning over the bump, the rules of epithelial healing. So how do you fix this? Because actually, if you look carefully with the fluorescein staining, you have negative staining because of the huge ridge here, because of the double ablation. So because you are now experts at diagnosis of corneal complications, you now understand why topography-guided treatments and wavefront-guided treatments were the wrong approach. Neither of these represent the stromal surface irregularity. They represent the front surface of the cornea. The wavefront is, 70% refraction at the front surface, and the topography is the front surface. So you're treating the wrong information. That's why these two treatments failed. And so the treatment in this case is actually to get rid of the bump. And that's what transepithelial PTK does. You take even layers out and you break through the epithelium and start lobbing off the bits of stroma that are sticking out into the epithelium. And so let me just show you diagrammatically. What we do is we can simulate the epithelial removal pattern. So if the thinnest epithelium is 41 microns. And you get a breakthrough right there. If we go to 47 microns, we have breakthrough here and here. So you can see we're going to start taking stroma now from that hole and that hole. And then we go to 59 microns, we're going to take more, and then 65, we've removed almost all the epithelium. We're just leaving a little bit here. So that stromal removal is as a result of the epithelial pattern, which is irregular. And we can actually, therefore, plot how much stroma is going to be removed if you do a transepithelial PTK, because it's a mirror image of the breakthrough pattern. And so now we can compare the amount of stroma that's going to be removed by a transepithelial PTK with what the topography-guided treatment from the same eye would have done. And as you can see, the patterns are quite different. And where the maximum tissue removal is going to occur, that's actually outside of where the maximum tissue removal is going to occur by topography-guided. That means that you're ablating the bump slightly off-center, which means you're going to deepen the crevice and increase the bump. And so if you have even a tiny decentration, instead of taking the bump out, you'll increase the trough. Now, how do you do a transepithelial PTK? This is where you pay attention. So let's flip everything around to the surgeon's view. And now let's look at that section and represent it here diagrammatically. And then let's look at how this looks intraoperatively. So you put the speculum in, you very gently dab the cornea dry because water absorbs the excimer laser. And then we program a PTK to 49 microns. Why 49 microns? Because we looked at our transepithelial PTK simulation. And at 49 microns, there's a very distinct pattern of breakthrough that we expect to see. And we see it here. Breakthrough here, breakthrough here. It's almost exactly what we predicted, right? Now we know that that the epithelial ablation profile rate that we're using is correct. And so now what we do is we do a second ablation. And now I'm going to go down to 65 microns. Now I get to 65 microns, I'm actually leaving a little bit of epithelium behind, that's this little bit here, and that's exactly what we find at the end of the procedure, right? So we have predicted the breakthrough pattern, and we have verified the breakthrough pattern by having what I call the photo stop opportunity. You know when you're driving in the mountains, in the Alps, and it says photo stop opportunity, and you park the car, and you take a picture, and then you get back in the car and you carry on. So this is the photo stop opportunity. Now, why did I stop there? Well, there's still a bit of irregularity. Well, if I carry on and take that out, I'm also taking a lot of stroma away that I don't need to take out. So what I do now is that I know from experience that the 65 micron PTK in this shape is going to induce about a +1 hyperopic shift. So what I'm going to do now is I'm going to program a +1 ablation. That +1 ablation takes very little tissue out of the center and more from the periphery, which is going to take out that last piece of epithelium that's here and smooth out that ridge 100% without taking more central tissue. And so we end up with no epithelium. However, we have a very irregular surface because this surgeon uses too much irrigation and doesn't know how to do the 0 microfold technique for flap replacement, which we teach at our course. And the way you treat that is by what we call wet PTK. So the wet PTK protocol is to flood the cornea with water, and then what happens while you're ablating is that the peaks are sticking out of the water. And so as the ablation hits, it hits the peaks only, but it's absorbed by the water around the peaks. And so you actually get a smoothing effect because you're only taking out the peaks. So here I'm using some anesthetic because it's been a while since we put more in. I'm ablating the water. It looks like a magic trick because it looks like you're doing nothing. But at the end of the one wet PTK, look at the surface. Really, really smooth compared to how it was just before I smoothed it. Yeah? So the wet PTK technique is great for polishing the surface of small microfolds. And so this is the result. We had this cross-sectional anatomy before. We completely regularized the bump. The epithelial profile gets regularized. It's almost like expanding the zone. There's the difference map. The topography is improved. Even the negative staining goes away, and the patient is, super happy and on target. So we'll go to the second case, which is this other one, which had this highly irregular Bowman's. We published this actually in 2006. This was one of the very first therapeutic cases I ever did. And you have to understand, I spent about 10 years scanning complications and just scratching my head, like literally not knowing what to do. And here is where we were starting to understand what to do. This was the first one. This was a NASA engineer who came over from Florida. He found the website, he found the fact that I had the Artemis, the Insight 100. He said, you look like the only guy who can diagnose things. So he said, the problem with my eye is that the eyes feel like they're fighting each other. He's an engineer, right? Low contrast, it just sees differently. He said, it looks like waxy vision. That's what he said, waxy vision. So his history was a -6 ALK, followed by some AK incisions, followed by a LASIK for hyperopic cylinder, followed by another LASIK enhancement and another LASIK enhancement. And he presented to me with -0.5 at 80. So, not that much refraction. And as we said, not too irregular a topography and not too terrible a wavefront. But he had very low contrast. And his orb scan looked pretty normal. However, the cross-sectional imaging was nothing like that. the Bowman's was highly irregular, and the epithelial pattern was thick, thin, thick, thin. So he had rings of thick epithelium. And you know the epithelium has a different refractive index to the stroma. So he basically had an array lens of epithelium on his stroma. And you remember what the patients who had the array lens put in, they used to say, my vision is waxy. So it was literally incredibly the same. So you do a transepithelial PTK, and you completely regularize the stromal surface, you regularize the epithelial profile, you regularize the cornea, you decrease the aberrations, and you jolt the contrast sensitivity back to normal. This is the photostock opportunity at 55 microns, and you can see the ring of epithelium that we expect, a little bit here. Everything looks exactly as expected, and this is a stromal difference map showing the rings of stroma that were removed to regularize the stromal curvatures, you know, these rings that were there from each of the successive treatments. Now let's go to the next case. This is radial keratotomy. And this patient is another teaching case report. So this guy had RK in 1982. Can I have some water, like a bottle of water, perhaps? The problem with refractive surgery. And the problem with refractive surgery is that the FDA, for example, does not approve repair tools. It puts in a lot of roadblocks for companies to be able to do therapeutic refractive surgery. In fact, you don't even have PTK approved in the States anymore. Unless you have an old Vizix, you can't do PTK in the United States. Which is bonkers. You can do a laser, can do a hyperopic astigmatism, or a mixed cylinder, or a myopic ablation with astigmatism, but you can't do a even ablation that doesn't change the refraction. It's bonkers, but that's the FDA for you. So we're selling cars without airbags. And so the very, very few patients who end up with irregular astigmatism in the US end up without hope. Unless they travel to Canada or Mexico or Uganda or anywhere that is not the United States. Because anywhere else in the world you can do topography-guided treatments. Even in Japan, where I don't think there is a topography-guided system approved, as a Japanese doctor, you can import a topography-guided treatment system yourself, personally, and do those treatments. So the Americans are literally the most retarded refractive surgery country in the world. Isn't that crazy? And I find that very irritating, but that's okay, because I'm American, but I left. And so I've got this theory. So my theory is that the reason why there is only 1% conversion of all of the people with refractive error into refractive surgery is follow my logic here. 1% of people wearing glasses and contact lenses have had refractive surgery. If you look at biological distribution systems that are normally distributed, 3 standard deviations is called normal. So anything outside of 3 standard deviations is abnormal. Well, what is outside of 3 standard deviations? 0.5% on this side, 0.5% on that side, that's 1%. That means that anybody who's had laser eye surgery so far is abnormal. We are abnormal. We're in the 1%. Then the other 99% don't want refractive surgery. They say, oh, I'm going to stick to my contact lenses. I'm not having the laser. Of course, the risk of contact lens wear, even if you wear daily disposables, at the end of 3 years of daily wear, it's the same risk as having LASIK. 0.1% loss of 2 lines, chance of losing 2 lines. And yet people will wear contact lenses for 12 years, taking 4 times the risk of laser eye surgery because they're misinformed about the safety of LASIK. Why are they misinformed? Because 127 people in the United States are pounding the FDA, and then the old head of the FDA, ophthalmic division, Waxler, he goes on the news and he's making money by saying, I would have never approved LASIK if I knew. It's like, you moron. What do you mean you wouldn't have approved it? You should have approved repair tools. It's like, who approves a car without brakes? No one. So the FDA is its own worst enemy. It's like it's a stupid system. They approve things without safety margins. And then they are scared of approving repair tools. I know for a fact that Doyle Stolting, who was head of the ophthalmic devices panel, that's the doctors that are consultants to the ophthalmic division, Doyle spent 3 years arguing with the FDA on a protocol to do topography-guided treatments for therapeutic refractive surgery. They couldn't agree on a protocol because they couldn't classify the eyes. Like, well, all the eyes are different, so you have to classify them, and then we can categorize them, and then do a trial. It's like, how about patient has a screwed up cornea? How about that for a classification? Anyway, it goes on and on. My hypothesis is that if we take therapeutic refractive surgery seriously, and that doesn't mean that all of the refractive surgeons have to do it, because the fact is the complications are so rare that if you're going to learn from only doing your cases, you're never going to learn. You're going to die before you become good at it. You're not going to have enough experience. What we need, at the minimum, is experts who do this kind of work on a regular basis and gather these cases, and we need collegiality between us to refer and re-refer back and be collegiate about this and not make a big deal of the fact that someone gets a complication, because it's biology. That's what the consent form is for. Anyhow, once we have therapeutic refractive surgery, I believe it will open the floodgates. Because part of the reason why, actually, quite impressed actually, there are very few people wearing glasses here. It's pretty good actually. The guy on his phone over there is wearing glasses, but he's looking down. Now he's laughing. Now he's going red. He's not having laser eye surgery because he's like, well, if something goes wrong, then what? Well, now you've come to the course. Now you know that if something goes wrong, it can be fixed. So, dude, come on, do yourself a favor. Okay, you might not be a candidate, I understand. But this is the point. If we had a repair tool that could be used by any surgeon without expertise, like Sri Ganesh, or me, or Alex Stojanovic, or Michael Mrochen, or Arthur Cummings, there is a few of us out there that spend ridiculous amounts of time on one eye. But you don't have to be like us. What if you had a product where you imported the MS-39, which has the epithelial profile, the stromal surface, and you push one button, and it calculates the stromal guided ablation profile, recalculates what the epithelium is going to do over that new surface in order to iterate how much sphere and cylinder to put in addition to end up on target. So I call that a PhD system. Push here, dummy. Okay? What if that product was available? And what if the lasers had to be sold with the product, no extra charge? What do you say about that? Who would like that? Wait a minute, not everybody? Oh, hold on a second. I'm going to do that again. All right. Let's start again. Take two. If there was a repair tool, which was a push here dummy PhD system where you don't have to know anything. You just import the MS-39, you got your epithelial profile, you got your stromal surface irregularity, it does the stromal surface ablation, and it recalculates the epithelium on the new surface, and then it knows what the refractive error is going to be, so then you can add in the sphere and cylinder to get the patient on target, and you could fix corneal irregularities in one treatment. Would you want that product? Put your hands up. Okay, so that's, let me see, yep, that's everybody. Let me just check. Oh, there's one here that slipped away, but he's asleep, that's okay, no problem. Okay, thank you very much. So, all right, you see that? I'm telling you. That is the product, okay? And here, I got a room full of refractive surgeons. Yeah, we got that? Okay, good. Okay, now it's your job. Okay, I'm going to send this to all the companies now. And I'm also going to send it to the FDA. All right. So look, we've basically finished on time, which I don't like doing. I like to run over, usually. But nevertheless, it's late. You've been exhausted. We've had a wonderful couple of days here in Seoul, Korea. The food has been fantastic. It's been, I've had a great time, and I hope you've had a great time. And I hope we'll see you at the ESCRS, for example, or APSCRS, or, oh, you have a question? Oh, sure. Well, yeah. Sure. Right. So if you had an accurate stromal surface guided treatment, you're right. You would lift the flap, do that ablation, and the epithelium would remodel. But because topography-guided treatments have the undercorrection as a result of the epithelial remodeling, we have to do transepithelial PTK to remove high levels of irregularity on the stromal surface before topography-guided, okay? The difficulty with highly irregular stromal surfaces in terms of stromal surface guided treatments is that I don't know if our laser technology and our tracking is sufficiently accurate to do that. And the beautiful thing about transepithelial PTK, as I said, is that because the epithelium is filling the nooks and crannies, even if the eye is moving around, you can never take stroma from the wrong place, because the breakthrough of the thinnest point of the epithelium determines where the stroma is going to be removed from. So I think the first iteration of this repair tool is going to be transepithelial PTK with a calculation of the stromal removal pattern that tells us the refractive effect of the transepithelial PTK, followed by regularization of the stromal surface, followed by recalculation of the epithelial remodeling, followed by a calculation of what that is going to do to the refraction, followed by alteration of the sphere and cylinder put into the treatment, followed by epithelial reepithelialization that leads to the target refraction. So that's actually what has to be done. And you won't believe this, but we are actually at a point where we're probably going to be able to start doing that. So if you look at clinicaltrials.gov and you look for my name, there's a trial which we're doing where we're doing a dry run on a software which I've developed outside of Zeiss with a grant from Zeiss, and which we are working now with Zeiss to commercialize. And we're doing precisely that. We're looking at transepithelial PTK on complex corneas, predicting what the shift in refraction would be, but with a side software, and then looking at the result and seeing if we would have predicted it. That's phase 1, and we're about to start phase 2 because phase 1 was successful. We're about to start phase 2 where we're actually going to put the refraction in advance and do the transepithelial PTK and see how accurate it is. That's step 2, and then obviously step 3 and step 4 and step 5. But you're right. Theoretically, if, for example, I do LASIK-based topography-guided treatments if it's regular irregularity. So decentrations in small optical zones, they can be done as LASIK. It's only if you have irregular astigmatism that you have to do transepithelial PTK first, because the topography is not going to represent that.
They have this abnormal corneal, abnormal topography, and you tell them using the topography-guided or the PPK. Have you had experience? Because we have cases that the young actually have regional size, and then they have to regular cornea because of that. I just wonder whether you have a case like that.
You know, in our part of the world, in England, we have very little pterygium. I know in your part of the world, it's really common. But again, it's going to be a function of the irregularity of the epithelial profile. The irregularity of the epithelial profile is the deviation from the topography. So a topography-guided treatment is going to be wrong by the amount of epithelial compensation. So if you're getting away with it, it means that you're regularizing the surface sufficiently that the epithelium can now come back and fully regularize it. Make sense? Okay.
The last one, apart from MX-39, do you have an experience whether the other ASOCT that you provide epithelial mapping, are they accurate? Can you take that?
Yeah. The only other system which is accurate that I can tell and has the right resolution and measurement precision is the one made by OptoView. It was the RT-View, then it was the Avanti, and now I think it's called Solex. The Solex will do topography also, but it does it from the OCT only. The MS-39 is superior to all systems because it has a placido, which is an instantaneous photographic surface from which it hangs the OCT. So therefore, the back surface is incredibly accurate. And so when you're doing ray tracing through the cornea, the MS-39 is going to be second to none. The other devices, like the ones that use swept source, they have pretty images, but very low accuracy. I'm talking about the Anterion, the Canon, the Topcon. I mean, they have epithelial maps, but the resolution, you know, if you move the cursor one square, it's like 8 microns. So it's not really useful for refractive surgery. The MS-39 and the OptoView systems. The Zeiss system is, it fails in some corneas, and it doesn't have a proper editing function, so you can't redraw the epithelium. Even the MS-39 fails in very irregular corneas, but it has a very easy editing software where you can manually re-edit the stromal surface patterns. So for now, those are the two devices. Of course, it goes without saying that the highest accuracy epithelial map is still high-frequency ultrasound. It has a 1 micron precision. The MS-39 is 3 micron accuracy precision. And you know, in my view, if you're going to start a clinic from scratch, if I was starting a clinic from scratch, I would not buy a Pentacam. I mean, this is pointless. I would buy an MS-39, the new one with the axial length. I would buy a Osiris for the wavefront, Corvis for all of my IOPs and the TBI and CBI calculations, and of course an Insight, because when I'm screening for keratoconus, the epithelial map from the Insight is the decider, and it has an algorithm with some machine-based learning which classifies corneas as to whether they're keratoconic or not, with huge sensitivity and huge specificity. And then if we have a suspicious cornea, we do the corneal scan. The patient's in the eye cup. We do the corneal scans, and then we go back and do the anterior segment scans. So the patient comes off the machine, and it turns out to be subclinical keratoconus. With the patient in the clinic, without any delays, we can now take the patient into the consultation room and explain to them that the safest way of correcting the refractive error is with a phakic IOL. And we already have the posterior chamber measurements, so we don't have to do any more testing. We can just book them for a phakic IOL. But we have the ciliary body inner diameter, which is the most accurate way of sizing, well, the ICL, which is what we use in London. So those are, now, it's gone from needing like 10 devices to needing 4 devices to start a clinic. Yeah. Guys, I did finish on time, but I got a little bit carried away with the philosophical stuff. Sorry about that. And thank you very much, and safe travels home. Should we take a kind of like a survivor's selfie, all of us? Yeah? Should we come on stage or do it like this? Do it from here? On stage, okay, on stage. Come on, everybody on stage. With the symposium.